Okay, it looks like it's top of the hour. Just a couple things before we get started. We will have time at the end of the session for questions and answers, and your certificates will be available this Friday by logging into your account. My name is Kim Colburn, and I am the Medical Education Specialist here for Medela in the U.S. I have the honor today of introducing our speaker, Dr. Thomas Hale. Dr. Hale holds degrees in pharmacy and a PhD in clinical pharmacology and toxicology. He is best known in the field of perinatology pharmacology, where he has extensively published in the use of medications in breastfeeding mothers. He is considered by most to be the world's leading authority in the use of medications in breastfeeding mothers. Dr. Hale is the director of the Infant Risk Center at Texas Tech University School of Medicine. This center provides evidence-based information on the use of medications during pregnancy and breastfeeding to physicians, nurses, lactation consultants, and mothers themselves. He is the author of 5 books in the field of pharmacology and human lactation and numerous papers and book chapters. His book, Medications in Mother's Milk, is now in its 19th edition. This book is a worldwide bestseller with more than 1 million copies sold in the last 15 years. He developed the lactation risk category, which is a rating system used worldwide for rating the safety or hazard of medications in breastfeeding mothers. Dr. Hale, if you're ready, go ahead and get started.
Okay, can you hear me all right?
I can hear you.
Excellent. Thank you for that introduction, and thank you all for joining us today to talk about a subject that I seem to be immersed in every single day. As Kim said, we run a call center here. We get about 100 calls a day, and you can imagine they are often some of the worst calls. But it's certainly been a learning experience for me for the past 30 years to find out what people are using in these breastfeeding mothers, and so it's going to be an interesting discussion today because the hottest topic in the field I'd suggest right now is probably the use of opioids and also marijuana, but to me. Since I see this every day, and I get a dozen to 20 calls a day that end up on my desk here to try to answer, it seems like the whole world is on bipolar meds and opioids. It's what it appears to me. It's not true, but that's a little bit about what we're seeing. Let me get a couple of these slides out, and we'll go on. This is nursing contact hours. This is me, and I'm formerly a Biohaven consultant.
Dr. Hale?
Yes.
I don't think you're sharing your screen. If you want to go ahead and pull your slides up.
Oh, really? Well, I'm going to have to figure out how to do that.
Go ahead and go back to your open share tray.
Open share. I got it right there.
Yep.
Is that it?
And then, yes, and then go ahead and put it in the presenting mode, slideshow mode.
If I can find it.
Down towards the bottom.
Yes.
Oh, that looks like it. Go back to where you just were. There you go.
No, I don't see it anywhere. Is that it? Show participant?
No, go ahead and close or click on your presentation, your PowerPoint.
Click on PowerPoint, yes.
Yep, there you go. And now go ahead and
oh,
there you go. Perfect.
Okay.
Okay, you're set. Thank you.
All right, thanks. And so it seems that every day we get these extraordinary calls. And for the last 30 years, as I've been doing it and developed the relative infant dose and things like that, we use the relative infant dose all the time. I felt quite comfortable with that until we started getting so many calls in. And then I realized there was one component that few of us really ever talk about, and that is the dose, the maternal dose. And all of a sudden, we were getting these calls with just extraordinarily high doses. And all of a sudden, it became quite apparent to me that we not only need to talk about the drug, the relative infant dose of the drug, and the actual maternal dose of the drug. And that's because every day I get questions about a product at extraordinarily high doses, and then it becomes real concerning. For instance, my nurse came in one day and said, "Dr. Hell, I have a call about methadone." And I said, "Well, why you ask me about that? We get that every day." And she said, "No, you don't understand." She said, this patient is using 600 milligrams a day, which is about 6 to 10 times the normal dose. So the dose has become really important to me, primarily because when you're talking about opioids, these things can be used in extraordinarily high doses. And as the dose goes up, so does the risk to the infant. But the method that we sometimes use, that I often use all the time when I try to determine whether there's a maternal risk or of a drug to an infant, you have to realize that when an infant is born, the plasma levels are going to be somewhat similar, not identical, but somewhat similar in many instances to mom's plasma level. And then for the next week or so, those levels are going to drop down until to the point that hopefully the infant's levels are quite a bit lower. Now, the important fact about that is that sometimes it's actually beneficial to wait a few days to breastfeed. It may be reduce the risk of some of these super high doses that we see with some of these medications. It may be even beneficial to go half and half donor milk, half breast milk. But the dose has become terribly important to us, and it's one of the top criteria, excuse me, that we look for to determine relative risk. And so many times what I try to do is we try to keep the mom breastfeeding somewhat, even if it's just half, and allow that baby's plasma levels to drop over time so that the amount that's coming in from milk will not produce extremely high doses to the baby. Because with opioids, there's always a risk of apnea in newborn babies, and you have to be extraordinarily careful with those. And so that when you ask the dose, that's terribly important. We're going to ask that. If you call us, we're ask that on every drug. We want to know what the dose is, and that's simply because we've been hit so many times with these extraordinarily high doses. Now, start with the opioids and opiates. The classic one that's been studied for many, many years is morphine and heroin. Morphine's been around for thousands of years. It's been used also too quite commonly in breastfeeding mothers, primarily because it's a pretty good choice. It's still one of my best choices for an opioid. That is to use morphine when you can, because its transfer to the baby is the transfer to milk is modest, and the oral absorption in the baby is quite minimal as well. We've got a number of studies, all of which are quite poor. I'll admit to you right now, they're quite poor studies. But nevertheless, we think that the transfer of morphine itself, the parent drug morphine, into breast milk is moderately low. It's kind of low. Super high doses, you might see quite a bit higher doses to the baby. But in essence, the relative infant dose is quite low for morphine, primarily because of poor oral bioavailability, even in the infant. The infant's liver is going to sequester about 70% of the morphine. It sequesters it in the infant's liver, and it just metabolizes and eliminates it thereafter. So the beauty of this drug is that the infant's livers are quite active. It is absorbing it and keeping it out of the plasma compartment of the infant. We do know that infants under a month of age have a rather prolonged elimination half-life, but we have very, very few case reports of morphine toxicity or morphine apnea occurring in breastfed infants. And that's primarily because of this poor oral bioavailability. We'll come back to another drug, the cannabinoids, the cannabis products, that also have terrible oral bioavailability, which is beneficial. The clearance of morphine and its elimination begins to approach that of an adult by about 2 months of age. So for the first month or two, you need to be a little bit careful. You need to watch these babies closely. You need to watch the dose, make sure the mom's dose is not exceedingly high. Make sure you know what the dose is. With some of these questions we get of mothers who have ended up in the hospital because they've taken an overdose of morphine or heroin or something like that, you may not know the dose, but it's important to recognize that with morphine products, while they're the best selection, perhaps, as far as an opioid, they also can be used in overdoses and become quite dangerous to a breastfeeding infant. Codeine is the prodrug of morphine. Codeine is actually metabolized in about most of the human population. We will metabolize codeine, 7% of it, to morphine, and then we absorb the morphine orally. And so when you absorb codeine into the liver, it converts into morphine to about 7%, and then that's what ends up in the plasma compartment of the patient. Now, we do know that there are rapid metabolizers, mothers that may metabolize instead of 7% up to 21 or 22%, and that can be a problem because the morphine levels in those patients could be quite a bit higher. In this paper, Gideon Corinne published this paper way back in 2006 of a mother whose infant died from her dose of codeine, and it was attributed to rapid metabolism, conversion to rapid metabolism, but that never really set well with many of us in the field as pharmacologists that work in this field. Never really quite set with us because it seemed that the plasma levels in the baby, the plasma levels of morphine in the baby were astronomically high. They were astronomically high, and we never could quite figure out how a dose via breast milk could ever reach that high. And so here recently, due to a lot of controversy, that paper was retracted by the journal. We don't really think that there's that much of risk even in a rapid metabolizing mom. Now, I know that may sound like heresy, but the reality is that even in a rapid metabolizer, their levels are not going to be that much higher that it would produce that higher level in breast milk. Basically, I've been involved in 3 court cases where the parents were suggesting that the maternal use of codeine caused the death of their infant. In 2 of those cases, the parents ultimately agreed that they had actually given the codeine tablet to the baby, to the infant, to quiet it down. And so there's always an ulterior fact that you may not know when you're asked about these drugs. So the question, but there's a lot of hysteria. When this paper came out in 2006, the FDA got all concerned, and everybody got all concerned about this, and they went in there, and the FDA rescheduled hydrocodone to a Category 2 drug. Well, now, and in your slides, it says codeine. I actually made hydrocodone. Hydrocodone was rescheduled to a Category 2 drug. And before that, for 30 years, hydrocodone was my choice of the best opioid drug for a breastfeeding mom. So it got recategorized as Category 2. Well, it turns out that no residents themselves can write for Category 2 drugs. So what did all the residents in the United States and the world do? They converted over to codeine, to acetaminophen and codeine. And what's really interesting is that the number of prescriptions for codeine actually went up 1,056%. That's what you call an unexpected consequence. And so I still think codeine is a suitable choice for breastfeeding moms. Methadone's been used for many, many years. We get lots of calls, almost a call every day about methadone. And the first question we now ask is, okay, what's the dose, Mom? What is the dose? We have a little bit of data on this, and we know that methadone transfer into milk is only about 2.8% of the maternal dose, so it's not terribly high. And then my nurse walks in one day with a dose of 600 milligrams a day. Well, you can see how that really impacts on those of us that answer these questions. So we've become really frenetic about asking doses of all drugs because you would be amazed at what some of these clinicians are writing for today. It's just unbelievable, 4 and 5 times the normal dose range of many of these drugs. So we've become quite careful about the dose. Methadone's quite all right. It's sometimes even used in babies to prevent withdrawal. And so it's not a bad choice as long as it's used carefully and under physicians' monitoring, such as you see in a NICU. So it takes a long time to withdraw these infants. So it's not necessarily a great choice for withdrawal in babies because it takes so long, nearly twice as long as other opioids to get rid of and to withdraw. Buprenorphine's kind of come back in popularity. It's not a terribly popular opioid drug because patients don't like it very well, to be quite honest about it. They just don't like it. They don't get that buzz out of it, that euphoria that they get from oxycodone or hydrocodone. And so it's never been terribly popular, which is the reason now we see it used all the time in drug treatment programs to get patients off of oxycodone or other opioids. You put them on buprenorphine with naloxone, and you've got a nice little product here that they can withdraw carefully with. And so we'll find we get this call consistently, buprenorphine in breastfeeding moms. The relative infant dose is quite low, so I think it's quite safe probably to use as long as the dose is not terribly high. Again, watch the dose on this one. Hydrocodone is still my drug of choice, but unfortunately, it's category 2 right now, and that's very difficult. And so people, unless they have a prescriptive authorities, can't really write for this, like our residents, which deliver most of the babies in the United States. But it's still a great choice. The total dose, the relative infant dose is 2.2 to 3.7%. I think it's still a great choice if the patient can get hold of it and the doctor can write prescription for it. It's kind of moderate potency, maybe 1.5 to 2 times that of morphine, but it's a nice oral preparation to use for post C-section and other trauma and painful conditions that the mother may be encountering. Other opiates, oxycodone, gosh, we get lots of calls about this. I hate this drug. It's just, I know patients like it. Oxycodone has a rapid onset and a rapid offset. It works real quick, but it also drops off pretty quick. And you're going to find the patients who are using this consistently 3 to 4 times a day. And they can be using high doses. I've seen 60, 80 milligrams a day used in some of these breastfeeding moms, and that's just simply too much to breastfeed with. Fentanyl is used all the time in epidurals. It's sometimes used as a fentanyl patch. It's a good choice analgesic as long as it's carefully controlled and monitored. It's a good product, relatively short half-life, which is really beneficial to a breastfeeding situation. Dilaudid, which is hydromorphone, when the FDA recommended that everybody stop using hydrocodone, and that then people suggest, well, why don't we use hydromorphone? It wasn't 3 months till we had a case report of a baby that was severely apneic from a mom using a normal dose of hydromorphone. This is a fine drug for really, really severe pain, but you need to be real careful with hydromorphone around a breastfeeding mom. Relative dose is only 0.67, but you got to be real careful. Just be careful with this product because it's potent, like 10 times more potent than morphine. So hydrocodone, morphine are generally safe to use in breastfeeding moms. Codeine is still somewhat controversial, but I think it's probably safe in most moms as long as you don't use really large doses and tell the mom to be very careful watch the baby for apnea. And if the baby is sleeping, can't be aroused, then you need to back off the codeine. Watch the high doses of oxycodone. Make sure in some of these cases, we always ask moms how they use it. Do they use it consistently, the same dose every day? If they do, the risk is not quite as high because the baby will become completely tolerant to it. But it's occasional moms we get that, well, I only use it on Monday or Wednesday. Those that occasionally use it are the higher risk ones because the baby won't become tolerant of it and may be exposed to a super high dose acutely. So watch the acute doses. The chronic doses are not so much to get worried about unless they're extremely high. And so tramadol is another one that's kind of come up in popularity. The reality is patients hate the stuff. They don't like it very well. They don't get a buzz or euphoria from it. And it's not too good at controlling pain. But you're going to see it used, and it's all right if a doc wants to use it. The relative dose is 2.8%. It's fine. All the nonsteroidals, ibuprofen, ketorolac, acetaminophen have been studied. Their levels in breast milk are extraordinarily low because their protein binding in the plasma compartment is 95 to 99%. Super high protein binding, therefore super low levels in breast milk, which is beneficial. Again, meperidine or pethidine, as they say in Europe, meperidine is a terrible choice to use in a breastfeeding mom. It is metabolized to a long half-life, extremely sedating, active metabolite. It's not a good choice to use. Gabapentin is another. It's an old anticonvulsant that has been remarketed for use with chronic pain syndromes like post-herpetic neuralgia or neuropathic pain. It's quite commonly used today in lots of patients. It does have a withdrawal. Most people don't realize this, but you can have a withdrawal. So if moms are using this while they're breastfeeding, you may expect a little bit of a withdrawal in the breastfed baby. Just kind of watch that. But I think it's relatively safe to use. There are very few untoward effects that have been reported. I've not heard of any thus far in moms. The doses are really quite high down here. You'll see doses way up to 3,200 milligrams a day with gabapentin. It's got a wide therapeutic index, so I think it's going to be quite safe. Watch for dizziness, drowsiness, slurred speech, things like that. Pregabalin is just another gabapentin-like drug. It is a little bit more potent. It has a little bit more popularity because the side effect profile is a little bit less. We have one little study on it where the milk plasma ratio is about 0.53. Relative infant dose is a little bit higher than with gabapentin, but I still think it's relatively safe to use in a breastfeeding situation. I've yet to hear of any complication with a breastfed baby. Ketamine, we have very little data. I'm just now getting ready to publish a case report with a colleague in another institution. Levels of ketamine are extraordinarily low in breast milk, which is going to be good news, but you're going to have to wait till we get some better studies out. Right now, I've just got one or two little cases that we've looked at, and it's just it's not enough data to really make a conclusion. I think it's going to be a good choice for pain and also for postpartum depression as well. Dexmedetomidine, hard to pronounce, but it is a really nice analgesic drug. It's an alpha-2 adrenergic agonist used for sedation. It's particularly popular in pediatric surgeries because it's so safe. We've done one study on and with a clinician friend of ours at Mayo Clinic in one breastfeeding mom, and the levels in that mother's milk were 15 to 89 picograms. Now, believe me, a picogram is really, really low. It's extraordinary, about as low as we can go on our instruments. So I think Dex is going to be a great product to keep a look at, but we don't have enough data really to publish much on it. So it's something we're watching closely to find out where it's going to go. Now, let's branch on off. That's kind of all the opioid stuff I want to talk about. Let's talk a little bit about some of what we call the endocannabinoid system. most people think of, when you think of the nervous system in humans, you think of the parasympathetic nervous system, acetylcholine, and the sympathetic nervous system, dopamine, serotonin, etc. You think of those two nervous systems. Well, in reality, the human body has another nervous system, and it's called the endocannabinoid system. It's only about 20 years old. We didn't know about it until about 20 years ago. But the endocannabinoid system has a different set of receptors for CB1 and CB2 receptors, and a different set of endogenous substances in our human body that activate these two receptor sites. Anandamide's one, 2-arachidonoglycerol is another one. Just this last year, I discovered 2-AG in human milk, and so we've got studies underway right now. My question is, what's it doing in human milk? Kind of an interesting conundrum. So the endocannabinoid system is the system that is activated by cannabis. That's the system. And the CB1, CB2 receptor sites are primarily in the brain for CB1, and the CB2 receptor sites are largely out here in the periphery. A lot of them out here in the periphery. And the way these things work is really novel. It's what we call, they are what we call retrograde inhibitors. And the way they work is when you activate the receptor sites here in the postsynaptic neuron, anandamide or 2-arachidonoglycerol comes out of up here. It then comes back here and it turns off the sympathetic system. It completely down-regulates it. And this is how we think that some of these drugs that are used for neuropathic pain, that's maybe how they work. They actually turn the presynaptic neuron off. And so it's kind of cool. And this is probably the natural way that the body works. The anandamide and 2-arachidonoglycerol, they feed back and they turn this baby off. They just completely turn the presynaptic neuron off. And that's probably how they control chronic pain. Really kind of cool stuff. And so the role of the endocannabinoid system in the human brain is really to influence the synaptic communication between neurons. It's what kind of shuts the neurons off, and it may be useful in processes such as eating and anxiety, pain control, learning and memory, and reproduction. And so it's a very important system in the human body. It's just totally misunderstood. We just don't understand much about it at all. There's a lot of research underway right now with the endocannabinoid system. And in the next 10 years, we should know a heck of a lot more than we know right now. But what's kind of causing this enormous interest in it is that the endocannabinoid system is, without a doubt, activated by marijuana. Cannabis is kind of an interesting product. There's a lot of hearsay evidence about it, and we don't have a lot of really good evidence because the number of studies are minuscule. And the reason there are not any studies, mainly the really hardcore studies, is because the Food and Drug Administration or National Institute of Drug Abuse has shut us all off. We simply can't do these studies unless we buy the product from the National Institute of Drug Abuse, we have a grant from them, et cetera, et cetera. It makes it all but impossible. And here in the state of Texas, I couldn't even get near this marijuana in a patient without getting arrested. So in some states, they're more lenient, but certainly not in other states. But the whole system has been largely impeded by the lack of research and the lack of our ability to do research due to federal regulations. We think that these are diseases that are commonly treated with cannabis. Anorexia, it's used for nausea and vomiting, but it's used for anorexia associated with chemotherapy, cancer chemotherapy. It's used very commonly in mothers for nausea and vomiting during pregnancy. It's used for neuropathic pain, quite popular for that, for inflammation. I've had a number of calls of MS patients that are using it for multiple sclerosis. It's used. We now have one component from cannabidiol, CBD, that is used now for epilepsy, and it seems to work in two types, only two types of epilepsy that we know of. pediatric epilepsy. It's been recommended for glaucoma, but you'd have to be stupid to use it for glaucoma. We've got excellent drugs to treat intraocular hypertension, which is glaucoma. And I don't know why anybody would want to use cannabis for this when you can use a really good drug that really, really does work. High doses can lead to schizophrenia. We've got a number of case reports on that. It's quite well known. It's particularly true in those younger individuals that are using the super, super highly concentrated derivatives. They take regular marijuana and soup it up to like 20 to 30%, 40% of THC, really super high doses. These patients, and now we're seeing classic cases of schizophrenia induced in those patients. You got to be real careful with high doses. The health risks associated with cannabis, we've known about these. Respiratory disease, chronic cough, phlegm production, chronic bronchitis, COPD has been reported. Motor vehicle collisions, that's been really reported. Great study done by a colleague of mine that did a study in which she took subjects and she put them in one of these machines where you're actually driving a car. You feel like it's a simulator that you drive a car in, and then she'd give them a whiff of marijuana. And what was really cool when she was telling me is that they could drive the car all right until something occurred, like somebody walks. She'd have somebody walk in front of the car in this simulation, and the subject would see that person walk in front of the car, but they didn't know that was dangerous. They didn't understand what it was, that it was hazardous, and so they totally lost a sensation of the hazard from marijuana if somebody were to walk in front of your car. So it's kind of scary. Low birth weight offspring, there's paper after paper showing low birth weight, slightly lower birth weight. It's not that much. It's like 3 or 4 ounces lighter in body weight. Almost all these studies, if they're honest, almost all of them show that also suggest that there's a conflict in their studies, and that is because we think somewhere between 15 to 25% of cannabis using mothers smoke cigarettes as well. We all know what cigarettes and nicotine do to reduce or produce lower birth weight offspring, and so we know that. So we consistently have this conflict in this literature. I think it will eventually turn out to probably be somewhat true that consistent heavy marijuana smokers may actually have babies with lower birth weight. But right now, it's so conflicted with the contamination with cigarette smoking, we can't really make that decision. So older breast milk studies that were done were just flat sorry. They're not very good. This patient came in, she'd been smoking it daily for 7 months, and they looked at her milk and she had some 105 microgram per liter. Well, when did they take the sample? Was it immediately after she smoked? Was it 6 hours after she smoked? No consistent, it was just not a very good quality study. Another mom here said she reportedly smoked it 7 times a day for 8 months. And she had a lot, 340 microgram per liter of THC. And so that is really, really a lot. And so we know that cannabis does seem to have somewhat an affinity for breast milk because it is so lipid soluble. And so we simply don't have a lot. And so my colleague and I, I'll get to that in a second. My colleague and I did a study, a really, really good pharmacokinetic study that I'll tell you about in a minute. In this study here, cannabis use during perinatal period, 3,200 respondents. Again, almost all of these studies are surveys, and they all have the same problem, is that you never quite know what you're getting from a survey type situation. And so prenatal cannabis was associated with a 50% increase in low birth weight. Again, it was conflicted with cigarette smoke. Why do moms use cannabis while they're breastfeeding? Well, it's really kind of interesting. we did this survey here, and what we found is that most of them report anxiety and stress is what they're using it for. Also some use it for depression, some use it for GI symptoms, some, a smaller 41% use it for chronic pain, some even use it for PTSD. But nevertheless, what we consistently, in survey after survey, find that about 70, 80% of moms report using it for anxiety disorder. It's really quite prevalent. The sad point there is that we have drugs, we have antidepressants like sertraline or Zoloft, which are great anti-anxiety drugs, which are much safer to use than cannabis would be, but yet mothers opt for using cannabis to treat their anxiety with, instead of seeking out some help with a really good drug like one of the antidepressants. So what about cannabis? There's good substantive evidence that it's pretty good for chronic pain in adults. It looks like it is reasonably good for chronic pain, arthritis, pain, etc. It looks like it is a moderately good antiemetic for chemotherapy from nausea and vomiting. The reality is it's not as good as ondansetron and other drugs that we have on the market. It's probably not as good as those are. So, but still, people suggest the use of this that it might be used for good for nausea and vomiting, and it's absolutely lunacy to use it for nausea and vomiting in a pregnant mom. It's just not smart to do that. But nevertheless, they do, and that's kind of what they report and what we hear. And it seems to be relatively good for treating multiple sclerosis spasticity, the symptoms from MS. There's really moderate evidence that it's good for sleep apnea, fibromyalgia, and chronic. And the evidence for pediatric seizures, I'd say, is moderately good. But the dose here is just extraordinary, 200 and 300 milligrams of cannabidiol, and the products you get over the counter are like 2 milligrams, 100-fold less. So you have to use the really concentrated stuff for these two pediatric seizure disorders. There's another syndrome that's awakening from the really chronic heavy use of cannabis, and that's what we call hyperemesis syndrome. It seems to be showing up when the really super high doses. I mean, these patients are using massive doses of this every day, and we see some severe nausea and vomiting from it, lots of abdominal pain. So these are just the opposite of what you might get with a really low dose of cannabis to treat abdominal pain, to treat nausea and vomiting. But when you up the dose, when you really increase the dose extremely high, then you get all these same symptoms over, and they're even worse. And now we know you can also get schizophrenic-like symptoms as well at high doses. There are actually 3 forms of cannabis, what we might call active forms. Delta-9 THC is the active component in cannabis. Its active metabolite, 11-hydroxy, is active as well, but it's real slow and hangs around a little longer, but it's quite slow in production. And then there's cannabidiol. Cannabidiol is not psychoactive. It is not psychoactive. It actually counteracts the psychoactive component. When you take CBD with THC, THC doesn't work as well. So that's been quite well known. And so the cannabidiol does not interact at CB1, CB2 receptor sites. It works at GPR55, a different receptor site. Cannabidiol is gaining interest as far as for use in chronic pain. And so it might be useful there, but the problem with that is you never know what you're getting when you go to the market and buy these. I went out and bought 4 different bottles of this at a dispensary, and 3 of the bottles had exactly 2 milligrams per cc in them. As they reported, we ran through our mass spectrometer. One of the bottles had absolutely nothing in it, absolutely nothing in it. And so you really can't really be sure what you're buying is really good stuff. I have a $200,000 machine that'll tell me that, but most people don't have that. Cannabidiol, I said, is non-psychoactive. It moderates, it smooths out the effect of THC, and some people use it for that purpose. Is it neuroprotective? We don't know. We think it might be, which is why it can be used in pediatric seizures. Maybe a chronic pain syndrome may be useful in chronic pain. A lot of people report that, but my problem with many of these is they rub it on the skin. And between you and I, you can never trust topical applications of any drug. Most drugs have to be formulated with certain kinds of excipients and chemicals in the solution itself to migrate, to take the drug through the skin. 99% of what you put on the skin stays on the skin and never gets inside. So all the topical preparations you see were formulated by experts in pharmaceutical firms to migrate through the skin. And cannabidiol in orange oil or one of these oils is not that way. It's simply not. So I don't know if any topically applied cannabidiol is actually absorbed. No one knows that. High first pass effect in the liver, about 99% is picked up in the liver and metabolized. Only a small 1 to 5% get past the liver. The same thing for THC. So THC and cannabidiol are poorly absorbed orally. I mean, extraordinarily poor. And so that's always something to remember. It's got a huge volume distribution. Boy, it really likes fat tissue. It'll stay around an adipose tissue for a long time. And so it's an unusual product that we just don't know anything about thus far, unfortunately. And no data on breast milk levels. I have one breast milk sample, and the levels were so low the machine could barely analyze it. It was so extremely low. So I need to do some more studies on this, and I'm trying to set up and do some of those studies this year if I can get moms to take some of this while they're breastfeeding. So we need to know a lot more about cannabidiol because it's so popular. Now let's get back to THC just a little bit because I want to go into a few characteristics, some pharmacokinetics of THC. The pharmacokinetics of THC are extraordinarily interesting because the reality is unless you smoke it, you don't absorb a great deal of it. And it is true that today's stuff is really a lot more concentrated. Today's stuff is as high as 23% THC. In many of these dispensaries, the THC content will range from 18 to 23%, quite high for THC. The plants have been altered. They've got techniques where when they cut the vine, they invert it vertically, and all that THC and the oils come down to the pods. And so there are little techniques they use to increase the concentration of THC in those plants. So today's stuff really hot. It's a lot of THC content in it. But in 20 years ago, 30 years ago, all our THC was about 4 to 5%. And so it was really quite low. But in this era, when you smoked a cigarette, you smoked about 600 milligrams of cannabis. And so you got about 23 to 24 to 20 to 30 milligrams of THC from a 600 milligram cannabis cigarette. Today, they don't smoke cannabis cigarettes, at least not big ones. What they smoke is a little tiny pod of about 100 milligrams. They put it in a pipe like this, and they smoke it. And guess what? They get the same clinical dose that they got 30 years ago. So don't believe this, that just because cannabis is 4 or 5 times more potent now, that you get 4 or 5 times the dose. That's simply not true because they smoke such smaller quantities in there that you're probably getting almost exactly the same excuse me, clinical dose of THC as you did 30 or 40 years ago when you smoked a whole marijuana cigarette. It's really kind of an interesting phenomenon, but most people have not picked up on it. Now, cannabis is really kind of cool in how it compartmentalizes very, very quickly. When you smoke a cannabis, you only absorb somewhere between 2 to 56% of the THC dose inside the cigarette or inside the pipe. And so it's very, very variable, so variable that it's made the pharmacology of inhaled THC really, really difficult to kind of understand. It first goes to the lungs, and then it dissipates quickly. Some of it goes to the brain, some of it goes to adipose tissue very, very quickly. And then after that, parts of it then go from the plasma compartment down to the liver, where it's then picked up and metabolized. But if you ingest it orally, then 95% is picked up by the liver, and a small percentage of that, 5% maybe, is converted to THC, 11-hydroxy-THC, which then gets into the plasma compartment. So oral is very poor absorption, and you get very low, much lower levels of THC in the plasma compartment. Well, what's really important about this compartmentalization is that whereas the concentration that goes to the brain is quite high initially, within seconds, it is redistributed back out of the brain, goes back into the into the plasma compartment, and ends up down here in adipose tissue. So, and I'll show you a slide here in just a second that really illustrates this excellently, and that it shows you how you inhale this, it goes to the brain, and then bingo, in 20 minutes it's gone from the plasma compartment and somewhere out. We call this in pharmacology redistribution. Propofol is another classic drug. You know, they inject propofol for surgical procedures. You're comatose, and then they stop the injection, and 5 minutes later, you're sitting there talking to the doctor. That's because it goes from the brain to the liver and adipose tissue in a matter of minutes. Well, THC does the same thing. This shows you one of the classic studies done by Marilyn Hustis, in which she put IV injections into she's put IV lines in patients, and she did plasma levels of THC after they smoked a marijuana cigarette. Here was a puff, here was a puff, here was a puff, and here was the last puff. And after each puff, you can see the plasma levels go up and up and up. And when they stop puffing, it rapidly falls. So it rapidly falls in a matter of about, 15 minutes? It falls from a high level of 150 way down here, and it keeps on going down here to almost nothing in about an hour to 2 hours. So it goes into the plasma, and then it's gone from the plasma. Now, the reason this is really important to us in the breastfeeding business is that if it's not in the plasma, it's not in breast milk. It's just that simple. And so this is a classic design of a drug that has high redistribution, high CNS levels, high adipose levels, but rapid redistribution from one compartment, the brain, to adipose tissue, where it's basically innocuous. It just sits there in adipose tissue for days and days and days. So keep this in mind, because this is inhaled. This is from a cigarette, inhaling a cigarette. This is from oral. This is the oral ingestion. And notice the oral ingestion goes up. It peaks at about 5 hours and then drops off about 12 hours. So it's much longer. But look at this peak right here. This peak is 0.7 nanograms per ml. Whereas if it in the smoke, when you smoke, it's see if I can go back, it's 150. 150 versus 0.7, not even 1. So you can see that the plasma levels are extraordinarily lower with oral ingested THC. And that's because so much of it goes to the liver here, and so much of it goes to adipose tissue, that it really never produces much of a plasma level, which is great if you're breastfeeding a baby. It's not as much of it is going to get to the infant. So marijuana kinetics, there's a slow release from adipose. It comes out over weeks of time. It just really loves fat tissue. The stuff comes out. It's picked up by the kidney and excreted in the kidney in extremely low levels. So what does drug screening tell you if you've got a mom that's drug screen positive? It tells you that mom's used this sometime in the last 2 to 3 to 4 weeks. But does that tell you anything about the clinical dose to the baby? In a minute, we'll get to that. Phase 1, the subject smokes a cigarette, plasma levels are moderately high. Phase 2, THC and the metabolites transfer to the plasma, then the CNS, then the liver, and then adipose. And here in adipose, it's stuck down there a lot. It's trapped in adipose tissue, and it just leaks out in minuscule, minuscule levels for days and days of time. And so that's the third phase, where it just leaks out over many, many days and weeks of time. Now, this is a really well done study in which they had marijuana smoking moms, and they took breast milk samples, and then supposedly the moms stopped smoking, and they continued to take plasma levels of the drug over upwards of 40 days. Now, this took a lot of effort to do this study, and what it basically showed us is that the level of THC in breast milk, excuse me, this is THC concentration in breast milk, not the plasma. It shows you that the concentration of breast milk, while they show you this 110 nanogram right up here, the average daily dose was 3 micrograms per day. 3 micrograms per day. That's 3 millionths of a gram of THC per day orally. Now, let's take that one step further. If you orally ingest in milk 3 micrograms, you're only going to absorb, a baby's only going to absorb 1 to maybe at most 5% of that. So you can see the dose the baby is picking up is infinitesimally small. Now, that's not what people want you to believe. They want you to believe that if the mom's drug screen positive, that she shouldn't breastfeed. But the reality is that if she's drug screen positive, it probably only means that the plasma levels are exceedingly low, and that only a microscopic quantity ever comes out of adipose tissue to affect the baby. And even if the baby does get it, it's only going to get maybe 1 to 5% of it at all. So this stuff is wonderful. It's a wonderful job, but it gives you the wrong impression. And the impression is that the baby's going to be exposed to marijuana. Sure, that's true, but they don't go one step further to tell you that the dose of exposure is infinitesimally small. Infinitesimally small. And so that's the most important thing for you to remember about when people are talking about this. This is the study that my colleague and I did. And basically, I'm going to rush through this so we'll have time. Basically, we took moms, we gave them a 23 milligram dose in a cigarette. We had them smoke the cigarette. And then we had a partner collect milk sample at 20 minutes, 1 hour, 2 hours, and 4 hours. These are breast milk samples, and we calculated the amount of THC in breast milk overdose, and we calculated the relative infant dose. The average relative infant dose is 2.4% of mom's dose. So the relative infant dose of the mom smoking is really quite low. But the next step from this is, if the baby gets 2.4%, it's only going to absorb 1 to 5% of this dose. And so that's really important, because their little liver's going to pick it up and they're going to metabolize it and break it down. The baby's not going to absorb very much at all, even though there's a little bit. It's absolutely lunacy to let mom smoke and breastfeed, and at the same time, it's just not a good idea. But if they wait as little as, say, 8 to 12 hours, then the risk, the amount that's in the plasma compartment is really quite small. This continues on down here to where it's almost undetectable. Had I gone out to 12 hours, we probably couldn't have even detected it in the plasma compartment. And the reason that you can collect it in the plasma or in the urine compartment from urine screens is because the urine, remember, is a filtrate. It's a filtered product of the plasma. It filters 70 liters of plasma for 1 urine sample. So you can see the plasma is infinitesimally small, and it is what we call it hemoconcentrates the THC in the urine. And so the urine levels may be many, 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 many times higher than the plasma level, and that's because of hemoconcentration. This shows you a graph. This is Marilyn Houston's study here, showing you 150 nanograms if you smoke it. This shows you milk levels if you smoke it as well. Milk levels are moderately high at 60 minutes, so sure don't want moms to be smoking and breastfeeding at the same time. You sure don't want that, even though the baby's still only going to get a small percentage of the dose. Still not a good idea. And so what do we need to know about this? We still need to know a lot more about the oral absorption of THC in the infant. No one knows this for sure. We know in adult humans, that the oral absorption ranges, as I said, repeatedly 1 to 5%. We don't know what that is in an infant. We're almost certain it's close to the same. We're very certain it's close to the same. And the reason that is that an infant has a much larger liver per body size than an adult does. So their liver is really much larger by body size than for an adult. What effect would repeat and continuous doses have on milk levels? I think over time they would raise the milk levels and raise exposure. So that's the study we're trying to do right now. We need to find a site somewhere here in the United States that might be willing to work with us on this, to find moms that are really chronic heavy-duty users, and let's do a milk study on them. So if you're one of those sites, please contact my infant risk center and we'll see if we can. We have the protocol all approved, we just need to find a site. How much THC would transfer to mom's milk following the oral use of cannabis? No one studied that. I think it's going to be almost too low to find it, but we had not done that study. It needs to be done. Does exogenous cannabis products, do they affect the endocannabinoid signaling system? That's a good question. I've been wondering about that myself. Why is 2-arachidonoglycerol, the classic human endocannabinoid, why is it in human milk? I don't know. And what's the long-term impact of exposing babies to cannabis? We don't know what that is thus far. There's all kinds of surveys that show slight increased risk of this syndrome or that syndrome. Again, I don't believe some of those surveys too much. Epidemiology is, in my opinion, not a very exact science. And I think we need to be kind of careful with that. Final, with opioids and cannabis, it's a wrestling match between the benefit of human milk, which is enormous, against the detriment of opioids. It is true that if a mom uses opioids all the time, her baby, she may have infant that is dependent on it, and you may need to let that baby continue to breastfeed to withdraw off of it. We do have studies that suggest that if a mom is using an opioid while pregnant, that she probably should continue to breastfeed so that it lets the baby down easier and the baby's withdrawal is significantly less. What's the reality with high-dose opioids? Be careful, be really careful. And if you have to, go half and half breast milk, half donor milk. Do something like that to avoid, wait a week postnatally, maybe wait a week before you introduce mom's milk any, but be very careful with the super high doses because, believe me, you're going to see them consistently. In chronic dependent moms, the infant is less sensitive to opioids. If a mom's been using high-dose opioids while pregnant, the baby's probably going to be quite dependent on it and is going to go through withdrawal. So you might as well let them breastfeed if they're going through a significant while. In non-dependent moms, the infant's at higher risk. If this is her first exposure, higher risk. To be more careful of. Introduce lower doses of milk, like I said, half and half donor milk for a week. Allow the baby to clear. I kind of like doing this in neonatal intensive care units because the docs are there and the nurses are there watching the babies carefully, and you can be a little bit more prone breastfeeding if the baby's in a NICU and the mom's being treated and the infant's being treated for withdrawal. So that's basically all I want to suggest today or talk about as far as these drugs are concerned. Just be real cautious, and if you're concerned about it, call the Infant Risk Center. We get, like I say, 100 of these a day, and I'll bet you half of them are about opioid drugs, and you got to be real careful with some of these products, particularly, and watch that dose. Please watch the dose. That's it. thanks for your attention.
Thank you so much for that information, Dr. Hale. Your work is absolutely amazing and it helps a lot of people. We do have some time for questions. I just put the link for the evaluation in the chat box for those of you that would like credits for attending today. And we did have a lot of people send a question in through the chat regarding the handouts. You can absolutely email education@medela.com if you'd like a copy of the handouts from today. We do have time for a couple questions. The first one is, on admission, how do we determine drug dose if a mother is using street versions of these drugs?
You can't determine that. No one knows that. With street drugs, it's probably going to be relatively high. If they're really hardcore addicts, it's going to be really super high doses. And so you're not going to be able to. But if she's using consistent street drugs, then the baby's probably going to be a dependent as well. And so in those situations, when you don't really know, I suggest go at most half and half for a week while the baby and the mom's being supervised, particularly the baby, particularly in the NICU, is being supervised. But it's a judgment call. You just can't always tell. You just have to use some of these little techniques. And I use this half and half all the time. When I get uncomfortable with a drug, or even when I know that the drug is high, like higher doses, I will sometimes go half and half just to be sure.
Okay, thank you. The next question is, what data do we have regarding decreasing NEC or the neurological development outcomes of premature babies when a mom has been using cannabis or has a positive urine tox screen for cannabis?
I don't know. I've never seen any data that correlates necrotizing enterocolitis with cannabis. I've not seen any. It seems like I saw a paper not too long ago that it probably reduces the incidence, but I can't be certain of that. One thing that does have a remarkable effect upon the incidence of necrotizing enterocolitis is breastfeeding. Breast milk reduces the incidence by 14-fold. 14-fold. It's been reproduced in multiple studies. So we know that just by breastfeeding a baby, a premature baby, you're going to reduce its risk of NEC significantly. So that is a real strong proponent for even if a mom's using cannabis, even if she's using opioids, it may be a higher, much higher safety factor to let that mom continue to breastfeed or to use donor milk, but use some sort of human milk in that infant to dramatically increase its ability to survive. Because NEC is devastating, and it kills lots and lots of human babies. And so when it comes down to which is more important, NEC or excuse me, which is a higher detriment, cannabis or necrotizing enterocolitis, it's NEC by all means. And so the risk of cannabis is minuscule compared to the risk of NEC.
Thank you so much for answering that. It does look like we're a little past the top of the hour. Just a reminder that your certificates will be available this Friday by logging into your account. And if you want a copy of the handouts, you can email education@medela.com and we'll get those out to you probably tomorrow or Friday. Thank you again, Dr. Hale, for presenting today. We really appreciate it, and have a great afternoon, everyone. Thank you for joining us.
Thank you. I didn't do bye.